Hello everybody. Welcome to number 1 Doctor channel. Today video is about otolaryngology ENT diseases, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about otolaryngology ENT diseases. Neck masses. Neck masses can be congenital, inflammatory, or neoplastic. Congenital masses are seen in young people, and typically have been present for years before they become symptomatic, get infected, and medical help is sought. The timetable of inflammatory masses is typically measured in days or weeks. After a few weeks an inflammatory mass has reached some kind of resolution, drained or resolved. The timetable of neoplastic masses is typically several months of relentless growth. Congenital thyroglossal duct cyst is located on the midline, at the level of the hyoid bone, and seems to be somehow connected to the tongue. Pulling at the tongue retracts the mass. They are typically 1 or 2 centimeters in diameter. Surgical removal includes the cyst, the middle segment of the hyoid bone, and the tract that leads to the base of the tongue. Some practitioners insist that the location of the normal thyroid should first be ascertained by radionuclide scan. Branchial cleft cysts occur along the anterior edge of the sternomastoid muscle, anywhere from in front of the tragus to the base of the neck. They are several centimeters in diameter and sometimes have a little opening and blind tract in the skin overlying them. Cystic hygroma is found at the base of the neck as a large, mushy, ill-defined mass that occupies the entire supraclavicular area and seems to extend deeper into the chest. Indeed, they often extend into the mediastinum, and therefore CT scan before attempted surgical removal is mandatory. Inflammatory versus neoplastic. Most recently discovered enlarged lymph nodes are benign, and therefore an expensive workup should not be undertaken right away. Complete history and physical should be followed by an appointment in 3 to 4 weeks. If the mass is still there, workup then follows. Persistent enlarged lymph nodes. A history of weeks or months could still be inflammatory, but neoplasia has to be ruled out. There are several patterns that are suggestive of specific diagnosis, as detailed below. Lymphoma is typically seen in young people. They often have multiple enlarged nodes in the neck and elsewhere and have been suffering from low-grade fever and night sweats. FNA can be done, but usually a node has to be removed for pathologic study to determine specific type. Chemotherapy is the usual treatment. Metastatic tumor to supraclavicular nodes invariably comes from below the clavicles and not from the head and neck. Lung or intra-abdominal tumors are the usual primaries. The node itself may be removed to help establish a tissue diagnosis. Squamous cell carcinoma of the mucosa of the head and neck is seen in old men who smoke and drink and have rotten teeth. Patients with AIDS are also prime candidates. Often the first manifestation is a metastatic node in the neck, typically to the jugular chain. The ideal diagnostic workup is a triple endoscopy or panendoscopy looking for the primary tumor or tumors. Biopsy of the primary or primaries establishes the diagnosis, and CT scan demonstrates the extent. FNA of the node may be done, but open biopsy of the neck mass should never be performed. An incision in the neck for that purpose will eventually interfere with the appropriate surgical approach for the tumor. Treatment involves resection, radical neck dissection, and very often radiotherapy and platinum-based chemotherapy. Other presentations of squamous cell carcinoma include persistent hoarseness, persistent painless ulcer in the floor of the mouth, and persistent unilateral lyric. Other tumors like acoustic nerve neuroma should be suspected in an adult who has sensory hearing loss in one ear, but not the other, and who does not engage in sport shooting that would subject one ear to more noise than the other. MRI is the best diagnostic modality. Facial nerve tumors produce gradual unilateral facial nerve paralysis affecting both the forehead and the lower face. Paralysis of sudden onset suggests palsy. Gadolinium-enhanced MRI is the best diagnostic study. Parotid tumors are visible and palpable in front of the ear or around the angle of the mandible. Most are pleomorphic adenomas, which are benign but have potential for malignant degeneration. They do not produce pain or facial nerve paralysis. A hard parotid mass that is painful or has produced paralysis is a parotid cancer. FNA of these tumors may be done, but open biopsy is absolutely contraindicated. A formal superficial parotidectomy or superficial and deep if the tumor is deep to the facial nerve is the appropriate way to excise and thereby biopsy parotid tumors, preventing recurrences and sparing the facial nerve. Enucleation alone leads to recurrence. In malignant tumors the nerve is sacrificed and a graft done. Pediatric ENT. Foreign bodies are the cause of unilateral ENT problems in toddlers. A 2-year-old with unilateral lyric, unilateral rhinorrhea, or unilateral wheezing has a little toy truck substitute for your favorite toy if you wish in his ear canal, up his nose, or into a bronchus. The appropriate endoscopy under anesthesia will allow extraction. ENT emergencies and miscellaneous. Ludwig angina is an abscess of the floor of the mouth, often the result of a bad tooth infection. The usual findings of an abscess are present, but the special issue here is the threat to the airway. Incision and drainage are done, but intubation and tracheostomy may also be needed. Bell's palsy produces sudden paralysis of the facial nerve for no apparent reason. Although not an emergency per se, current practice includes the use of antiviral medications and as is the case for other situations in which antivirals are used, prompt and early administration is the key to their success. Steroids are also typically prescribed. Facial nerve injuries sustained in multiple trauma produce paralysis right away. Patients who have normal nerve function at the time of admission and later develop paralysis have swelling that will resolve spontaneously. Cavernous sinus thrombosis is heralded by the development of diplopia from paralysis of extrinsic eye muscles, along with facial pain and high fever, in a patient suffering from frontal or ethmoid sinusitis. This is a rare but very serious emergency 30 mortality that requires hospitalization. Diagnosis is best done with MRI. Treatment is based on early and aggressive 4 antibiotic administration, for a minimum of 3 or 4 weeks, with penicillinase-resistant penicillin plus a 3rd or 4th generation cephalosporin. While the cavernous sinus itself would not benefit from operative intervention, the responsible paranasal sinuses should be surgically drained. Epistaxis in children is typically from nose picking. The bleeding comes from the anterior septum, and phenylephrine spray and local pressure controls the problem. In an 18-year-old the prime suspects are cocaine abuse with septal perforation or juvenile nasopharyngeal angiofibroma. Posterior packing may be needed for the former, and surgical resection is mandatory for the latter. The tumor is benign, but it eats away at nearby structures. In the elderly and hypertensive, nosebleeds can be copious and life-threatening. The blood pressure has to be controlled, and posterior packing is usually required. Sometimes surgical ligation of feeding vessels is the only way to control the problem. Dizziness may be caused by inner ear disease or cerebral disease. When the inner ear is the culprit, the patients describe the room spinning around them. When the problem is in the brain, the patient is unsteady but the room is perceived to be stable. In the first case meclizine, promethazine, or diazepam may help. In the second case, neurologic workup is in order. Full-fledged Ménière disease includes vertigo, tinnitus, and hearing loss. It is treated primarily with diuretics. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.